association with the Joanna Briggs Institute goes back several years now. I've co-supervised several ENT students who completed the JBI Masters of Clinical Science. The first student I supervised was Stephen Cow, and so I've had a very enjoyable and association with the JBI. Now, Craig asked me to talk about types of surgical research, quality of surgical research. I thought I'd touch on systematic reviews and why they're useful in surgery, how we choose a surgical topic, and some of the challenges. And then finally, I touch briefly on clinical equipoise and surgical interventions. So why do surgeons do research? Well, it's a good question. This is the standard box. This is the standard answer for evidence-based medicine. So you just swap medical decisions for surgical decisions. But in essence, why we do it is we for a number of reasons. We want to improve the surgical care that we have. We want to advance surgery. We want to improve outcomes for our patients. And we also want to do research that meets the needs of the patients as well, and these change, and also it improves our academic track record, helps with getting grants. It helps with getting for surgical trainees for people wanting to become surgical trainees to get into training. It helps to train your mind to think in a research way. So there's lots of various reasons why we do research. So this is a standard. I'm sure everyone's has seen this, the hierarchy of evidence-based medicine. And I put this in here mainly to show that randomized controlled trials are near the top of the pyramid, but systematic reviews of randomized controlled trials and systematic reviews here are right at the very top of the hierarchy of evidence-based medicine. A lot of research evidence you hear is often background information, Google, expert surgeon, expert opinions. So what's the importance of doing research? Well, these are just some stories of what happens, the benefits of doing research. For example, there's some of these trials here shown that things such as some of the treatments used for multiple sclerosis or some of these treatments for shoulder pain were all found to be no better really than placebo or not doing anything. And there's been a variety of other different sham surgeries, which has shown that it's of real no benefit. But they still continue to be practiced until this sort of evidence comes out, and then slowly people start to realize that we're doing surgery that is really not of benefit for the patient. This was a controversial statement back then in 2016. Back pain, there's a lot of back surgery done for pain. And some of that obviously is indicated and of significant benefit. Some of it is a placebo effect, and patients are really no better off than with physio and steroid injections or other treatments to manage the back pain. This one's of relevance for ENT surgery. Meniere's disease is a condition of the inner ear where the patient is still poorly understood. But they get recurrent vertigo, and they can get quite severe recurrent vertigo. And there was a procedure done back in the 70s and 80s called endolymphatic sac shunt surgery. It was very popular, and a lot of patients were having this surgery done for their Meniere's disease. What we learned about Meniere's, though, is that the natural history of it is that mostly can be managed with medically. And then secondly is that the disease seems to burn itself out after usually a number of years, sometimes up to 7 years. Then the vertigo seems to resolve. Anyway, so these surgeons did this trial, where they did an operation on the patient's mastoid, and in one group they did this endolymphatic sac shunt surgery. And in another group, they did incision on the ear and the mastoid, but they didn't do the sac shunt surgery. So it's a very interesting surgical trial because you essentially inflicting an incision on a patient, submitting them to general anesthetic, submitting them to some postoperative recovery and pain, but you're not doing the operation. You said you would. And this is one of the challenges in doing surgical randomized controlled trials, which we'll come on to later on. And so this study back in 1984 showed actually that there was really no significant difference at all, and that the shunt surgery was really no better than doing no surgery. And so patients who underwent the sham one felt they got better. So there may be some element of placebo effect as well. So following this trial, endolymphatic sac surgery has since fallen by the wayside. So what types of surgical research are there? So as I mentioned before, you've got opinion papers, and these can get published. So this is a paper that I published with one of the residents. And basically we did a review paper on penetrating neck injuries. And this was just a narrative review, not a systematic review. We selected, we did do a literature search, but it was done in not in a systematic way. And we selected articles that we thought were of relevance and interest, and came up with some general consensus and opinions. I put this article in here. This is one of my first articles when I was trying to get into ENT training. Again, it's a review article. These sort of articles now would be very hard to publish, but back then in 2002, I found a number of patients with this and did a review article. But back then it was easier to publish this sort of review papers. And then there's case reports. You got to start somewhere. So yeah, that's what I started with. My very first, one of my first papers was a case report, which was just a single patient who had this very rare complication that got published in the ANZ General Surgery back in 2002. Nowadays, it's really, really hard to publish a case report. There are some journals that specialize in case reports only, but other than that, most of the major journals won't really publish case reports. And the reason for that is that case reports, unless they're really presenting something very rare or something unique that we can learn from, and they are useful. So don't get me wrong. I mean, case reports do help advance knowledge, but unless if there have been other similar case reports of a condition or an operation done before, then really it doesn't add much more to the body of knowledge out there. Then you get your case series or case control. So case series, just a series of patients who might either have the same disease or undergo the same surgery. And then case control is similar, but you've got another control cohort, which are similar population, but maybe one underwent an intervention and one underwent a different intervention, and you following them up prospectively or sometimes retrospectively look at the case roads and try and see the difference between the two populations. So it's an observational study rather than a randomized trial set. So with these observational studies, something that I published as well, and I was a resident trying to get into ENT training. And it's just simply patients who had this particular tumor underwent a particular approach, surgery, and what were the results. And these articles are one of the most common type of articles you get in surgery, case series, and even that just published this year in June, another case series we did on robotic surgery. So the next type of studies, surgical research, you get cohort studies, and again these are, as I mentioned before, very common in surgery. You usually done retrospectively in surgery because somebody will say, oh well, look, we've be a consultant, or someone says, oh look, we've had these type of patients over the last 5 years or 10 years or something like that, and it'd be interesting to see. This is what I think is happening, but it'd be interesting to see what's actually really happened, because our view is very easily influenced depending on how many years it has been since we've seen the patient. We might think everything's gone well, but when we look back at case notes or we follow them out long enough, we find that the early outcomes may not be quite the same as their late outcomes. So anyway, these are sub papers that are commonly published. And then surgeons can do randomized controlled trials. And so these are some of the example of trials that I've been involved in. This was a very major four-year trial where we randomized patients into multi-level upper airway surgery versus best medical management to treat patients with moderate to severe OSA. And this is a very important trial. It's the first surgical trial for OSA using this type of surgical approach in a randomized control manner. So it was very rigorously done. It was funded by NHMRC. It took us 4.5 years because we screened thousands of patients, and because of the strict criteria, we ended up with about 100 and about just over 100 patients in the trial. And I'll come to and then you got this sort of other trials which I've done, which was a smaller type trial, but again a randomized trial. We're just looking at simply, one patient having sinus surgery on both sides, and one side having a stent and one side not having a stent, and these were the outcomes: reducing adhesions and middle turbinate lateralization. And then these ones in medical trials in patients with sinus surgery, so irrigating with Manuka honey versus no Manuka honey, and seeing what the outcomes are. So there are certainly randomized controlled trials in surgery. And then so some of the challenges, I guess, with systematic reviews in surgery can be challenging with case series and case cohorts, case controls, is that usually retrospective, the outcome measures are uncontrolled, there's missing data, there's risk of bias, because usually only positive trials, sorry, not trials, positive studies are published, negative studies are not published. There's also risk of bias because they don't all describe the case series the same way, and some measure it slightly differently, and so there's all these real challenges with trying to do systematic reviews in surgery, because a lot of the research is mainly still case series cohort type papers. So there are some systematic reviews you can do in surgical topics. These are just examples of one that I've been involved in. And some of these are my former students, as you can see, Vimal, who did successfully completed a master's, JBI master's, and Somya as well. She also did that. It was excellent work. And Stephen Carl, my first student, who did this, and he did several systematic review papers with me after that. And this was the first paper that he did. It's just more for to look back and see how far he's come since then. And then there's also scoping reviews, which are interesting. So these are, if you look up this paper, what's the difference between systematic review and scoping review in open BMG open access? BMC open access here. So scoping review is looking at what is the type of information out there, and it is very useful scoping out what's available in there, and that can lead to either then people saying, well, this is the missing bits of information and we need to do this next to fill in the gap. So they can be quite useful. So what are the advantages of doing a systematic review? So these are some of the advantages I tell my students. There's no need to deal with human research ethics committees, and that's a really big plus. Because back ethics application and back and forth with the ethics committee it can take months sometimes to get a proposed clinical research project through. You can do research that's not affected by a global pandemic. I had a master's student last year whose research was affected for months because of COVID. They didn't want to do any research on these patients because of the risk of COVID being exposed to the student. So this advantage is a big advantage. You're not relying on recruiting patients. So if you're trying to do clinical research, there's lots of variables. Patients sometimes don't turn up. Patients decline to be part of the study. You think it's going to be easy to recruit patients. It's sometimes harder than you think. The other big advantage is you can do it while you're still working, either full-time or part-time. And so that's a big advantage, I think, for surgical residents. Craig asked me to talk about why surgical residents might want to do a systematic review. There's lots of different motivations, and depends on their interest and motivation. I think certainly learning how to do it is a very important skill, and it's a way of advancing knowledge. Because there may be a whole bunch of papers out there, and no one's looked at it systematically to try and pull it together. And so I think, and this way can advance our knowledge. And it's something then that you can use for for the future, for many years to go. Whereas some lab techniques you learn could be superseded by different lab techniques as you go along. So that's one of the advantages of learning how to do a really good systematic review. You can undertake a research higher degree. So having that qualification is good for you to get into training for future jobs, to continue to supervise students. I did a PhD. I was very interested in academic surgery, and I've continued to do that since. And without a PhD, I wouldn't be able to do, I think, do good research, be able to supervise students, be able to apply for grants, etc. And then I think probably one of the biggest things here, although I put it at the bottom, it's probably one of the biggest motivations for surgical residents is we give points for people trying to get an ET training. So these residents wanting to do specialist training, and there's a number of points they can get for papers and research higher degrees. So that's a good motivation factor there. So how to choose a surgical topic? I think importantly, it needs to answer a specific relevant clinical question. So that's where having a clinician, if you're going to do a systematic review in surgery, it's got to be something obviously that is surgical, but also something that remains either unclear or uncertain, or something that's common that we want to know the answer to, and a systematic review could help us with that. You got to be careful with your question. You don't want the question to be too broad, or the topic to be too broad. You end up with a lot of abstracts to review, and that becomes a real pain. For example, I did a systematic review with my fellows and Stephen on biologics, really, but immunotherapy back then, immunotherapy for chronic rhinosinusitis, which is a very emerging thing. And it's a very important review paper. But what we found when we were searching was that we picked up a lot of immunotherapy for allergic rhinitis, hay fever. And so we ended up with thousands and thousands of abstracts that were we had to go through. So in the end, the paper still got done, but because of the way we structured it, it was too broad. We had too many abstracts to review. You got to delineate the study population type and be quite clear and specific, define that, run a very clear inclusion-exclusion criteria. And then you want to be able to critically appraise the article's quality and bias, and you've got to include that in the paper. I think that's very important. So I think for surgical residents, any student, not any student wanting to do a surgical topic in systematic review, is find a surgical supervisor to provide some clinical context. There's a number of academic surgeons around who will be more than willing, I think they'll be very happy to supervise you. Look for, I think, niche topics, or those that are have certainly been in the last 5 to 10 years. Problem with topics, if you pick some that date back to the 60s and 70s, is obviously you've got to search more, and the quality of the research then and now, it may not be the same. And so there's sometimes maybe a procedure or disease that's only recognized in the last 10 years, and then those are the sort of good surgical reviews you could do. Or sometimes there may be a number of multiple small randomized controlled trials, and that's quite common in sinus surgery, where they might have 20 or 30 patients in each arm of a randomized controlled trial, and then grouping them together gives you enough numbers and power for a meta-analysis. Craig asked me to talk what I thought about the grading of recommendations. So I don't know if you all are familiar with this, and so because when you do your systematic review and then you find your you come out with you have your results, and then you got to make you got to discuss them, and then you come up with some recommendations or conclusions, and so we're grading that sort of work, and we're thinking, okay, high. So we think that what we found is very similar to what is really happening, and sometimes we think, okay, it's very low, what we found is probably quite different from what we think is really happening. And so you might grade the quality of the evidence. So you might see this in consensus guidelines and documentations where people grade the recommendation being very high. So there's lots of really good, strong evidence to back up the recommendation. Or it might be low, as in there's only a few low quality papers that find this, and then it's either a lack of research, or the papers we found are very have very wide range of findings, and so it's very hard to work out what the true effect is versus the estimated effect. It is certainly helpful understanding how much confidence we can place in the recommendations of systemic reviews and guidelines. This is something from the BMJ back in 2004, when reviews were really coming into the forefront. And back then, you can see randomized trials considered any evidence was considered very high, any other evidence was very low. And then it gave points to the type of the study, and overall came with, so if you've got a very number of high points, then you very strong evidence, etc. An example here of grading. So I think it is a very useful way, and especially for maybe for non-academic surgeons. If you look at this recommendation and they outline what does it mean, benefits clearly outweighs harms and burdens, and then so this is the ATA guidelines, American Thyroid Association guidelines for managing nodules. So then the implications, what does it mean, patients, clinicians, and then for policymakers. So very strong recommendation, it can be adopted as policy. I mean, this is sort of research evidence you want, which can change policy. And clinicians feel they would agree with it. So what you found from research is generally in agreement with what most clinicians feel anyway, those doing research or not. And then most patients would also agree to have this. So when we do systematic reviews and research, eventually that's what we wanted to get to be able to influence policy, patients, and clinicians. So something to think about when you're writing your systematic review and conclusions and discussion is around what the recommendations would be and implications from the findings of your review. And I'll skip through this again, because this goes similarly. This is the how to describe the type of supporting evidence behind it. So you can see most people rate RCTs as higher and observational studies in case series lower. So just go right through some examples of some systematic reviews in surgical field and endoscopic sinus surgery. So this one here is we're doing sinus surgery. This is what we call poor surgical field. You see lots and lots of bleeding. Trying to do surgery, and it's bleeding like this, and you're trying to curate things. And then on this side, on the right here, doing sinus surgery, there's very minimal bleeding. This is what we call good surgical field. They operate safely, quickly, efficiently, and less risk of complications. So we know this. So the goal, this is just an example. The goal of sinus surgery is to get as good as you can with surgical field. And so this is an example of how systematic review can give us guidelines in this. So there's been loads of papers published on different techniques you can use to help improve the surgical field endoscopic sinus surgery. And that's been over the last 10 years or so prior to this. And so you can pull all that together, all the different studies people have published, and come up with some overall conclusions. So now it's generally, when I was a surgical registrar training, I was the QH part of this. A lot of this work was done by PJ Wormald, and it's just good to see that other people around the world also, researched it, and then eventually now we know for sure that TIVA, type of anesthetic technique, improves the surgical field. You can see the comment, there's lots of heterogeneity and inconsistency in the way they grade the surgical field and the different outcome measures. So this is certainly one of the challenges in surgery, to do systematic reviews, but it can lead to overall recommendations that changes surgical practice. So let's skip this. So one of the challenges is surgical research. Surgery is very different from a pill. It's certainly difficult to have a sham surgery arm, or it can be done. It is hard to control, standardize. So one of the things about surgery is that there is a bit of an art of surgery, and And it might surprise people, but how, like for example, tonsillectomy, it's one of the most common ENT operations we do. But I guarantee you, if you put up a question or discussion topic in an ENT conference on tonsillectomy, it will generate a huge amount of debate. Everyone's got their way of doing a tonsillectomy or their own little tip or little trick or something different. My way is better than someone else's, and so even something like tonsillectomy is very hard to control and to standardize. It's very hard to blind a surgeon during surgery trial. Probably not safe. Surgical techniques evolve. There is a learning curve, so it's not like you suddenly like it's almost like research on the go. We say, oh, we'll try this in the next patient. I'm sure maybe patients don't want to hear this, but it's sometimes what happens. We try something different during surgery, and we go, this one works, so we try a bit more, we modify it, we evolve it, and then we get better and better at it. It's never been that there are some operations we do which are fairly standardized, but there are a whole lot of operations we do which have evolved even when I was a registrar to now as a consultant. And it's really hard to know when does innovation within surgery become research and when is it just clinical practice, which is a challenge for surgical equipoise. So, for example, sinus surgery evolutions, because I do a lot of sinus surgery, that's why a lot of my talk is around sinus surgery and cancer, which is what I do. So back in the days before endoscopic sinus surgery came along, people did external ethmoidectomies like this to do a sinus surgery, and incisions under here, sublabial approach to get to the maxillary sinus, which wouldn't happen nowadays, really, unless we're doing it for cancer. So we don't do sinus surgery anymore through these techniques. But endoscopic sinus surgery came along. We never did any research to compare external with endoscopic sinus surgery. We just evolved, we switched, and no one ever went back. So it's interesting that, I look back at it, that a complete change in the way we did sinus surgery happened, and we never did any research to show that sinus surgery was better than what we previously did. But we all knew it was better because you could see more. We've got stealth navigation here. Look at the technology. Again, stealth, this navigation technology came in where you can pinpoint where you are in the operation using special software and tracking devices. We use this for very complex revision cases or skull-based cases. But this sort of technology got introduced and never really was tested in a randomized trial or any other research. So here I'm teaching my fellow that he's doing sinus surgery. We've got all this monitoring now, which has come along compared to all this without really any significant research behind it. And this is an example of robot prostatectomy. And we see that robotic prostatectomy just keeps going up, and laparoscopic open is going down. And this is across the world. And now, if you ask urologists around Australia what would they do, it's all robotic prostatectomy. Even though there's been trials published which show that the difference between robotic and open prostatectomy is mainly in days of in hospitalization is the main outcome. And a lot of the benefits of robotic prostatectomy have not been shown in a highly significant way. But still, the whole practice has changed. You ask any patient now, they're all going to have robotic prostatectomy, and there will only be a very, very, very small group of patients that might still have open surgery. So changes in surgery occur despite research. And as you can see, if you blinded a surgeon, it'd be quite dangerous driving and also operating. But you can do blinded studies of patients. And with this is a patient that had, this was when laparoscopic cholecystectomy emerged, and they were comparing it versus an open or mini laparotomy. And so what patients did was they underwent the open cholecystectomy and laparoscopy they randomized into, and then they all had the same dressings on it, and they all treated the same way postoperatively, and patients couldn't really tell the difference. So this is interesting. They could blind the patients, and so they took away that sort of placebo effect that you might get, and patients actually found that mini laparotomy cholecystectomy was slightly better than laparoscopic cholecystectomy. But you look at it now, it's all done laparoscopically anyway. So sometimes what might be a really good idea and still done well, still doesn't really change surgical practice because there are other reasons driving the evolution of surgery besides research. I'll just go back again to this. This is just to show you that you can do good surgical research if the clinical question is an important clinical question. So there are other ways to do research in surgery other than trials and case series. So continuous clinical performance improvement. So use of databases and prospective audit is one way of looking at the evolution of surgery within, say, your institution, across the country, or across the world. Finally, it's going to quickly touch on ethics and equipoise. If you're familiar of the Tuskegee syphilis study, so this was a terrible disaster, and it certainly led to big changes in the way in ethics committees being set up and everything, and research being very much more rigorously regulated and governed. And also, but this Tuskegee study also led to a lot of harm, and a reason why a lot of African Americans don't trust research in the US because of what happened. So basically, there was this area, Tuskegee was where patients had syphilis, and they were not treating them, but the patients were told who participated in the study that they were receiving treatment for it, and they were receiving free healthcare for it. And the study went on for 40 years, and the idea was to see what would happen with the natural history of syphilis without treatment. I think you all be pretty shocked now that this happened. This sort of study happened back then, and even was occurring up until 1972. This is another study to bring us to the question of ethics and equipoise. So this was a randomized clinical trial done in published in JAMA, and breastfeeding women who were breastfeeding were randomized into breastfeeding or formula fed. So this trial was done, was published. The question they wanted to know was what was the risk associated with with formula feeding. The issue, this trial was controversial in the end. Now it was because the mode of transmission of HIV was known then. So basically, it was known that there was a significant risk of passing HIV from infected women, mothers, to their infants through breastfeeding. Yet the study was approved, allowed to continue, and finished. And a number of patients in the breastfeeding arm did get infected with HIV-1. And so that brings you the question of, should this trial even have been allowed to, when there's a known risk to the infants randomized into the breastfed arm? So surgical equipoise, and any equipoise really, it's when there's a state of genuine uncertainty on the part of the surgeon regarding the comparative therapeutic benefits of each treatment or each treatment arm in a trial. So in essence, what it means is that if you know that something is better or harmful or risky, then you really should not be trialing it, or it makes it difficult to run a trial. So that's one of the challenges in surgical research, because if you think that a certain operation or certain approach is of benefit to the patient, and then you want to randomize them into something else, you really shouldn't be doing that. That's the challenge of equipoise. You need to be in a situation where there's really genuine uncertainty, and this is where all the research background, literature review, systematic review, scoping reviews, and all that bring all this sort of evidence in to help guide surgeons and patients. And then also a lot of it is experience and your local institution experience. So those are the Tuskegee and the African ones, studies that I've shown you before, just examples where research caused more harm. And there was evidence already then that there was harm, risk, or minimal benefit, and really shouldn't be, well, I think, be testing that out. if there is of minimal benefit for the patient or of some risk to the patient when you're doing research. And you got trials like this which are good, which showed this was a robotic trial versus radiotherapy, transoral robotic surgery. This is a randomized trial, and it showed in the conclusion, the end was the difference did not represent a clinically meaningful change, and toxicity patterns differ between groups. So patients with oropharyngeal cancer should be informed about both treatment options, and so there's some uncertainty there. And so I think surgically we should not sway patients either way, and patients should be able to make that choice. And that's the challenge of Equipoise, is to recognize when if there's genuine uncertainty versus that there is one way better than the other. So that brings me to the end of my talk. I think it's almost 10 o'clock. Sorry. I was a bit delayed, but anyway, hopefully that covers what you wanted, Craig. And I'm happy to take any questions.
Actually, while they're warming up a little, I had a question about how you personally approach the planning and development of a systematic review topic with a student. I wondered if you could tell us a little bit about that.
Well, yeah, so first, if I have a student, find a student, come see me. Yeah, usually I guess because I look at papers regularly, and then I'll say, oh, well, there's been a number of papers over the last few years, on this, and there's a bit of uncertainty here. We should look at doing this as a systematic review. And then I said, oh, why don't you, I might send them a few PDFs to look at, and then say, well, you have a look at that, and then get back to me, and then we can do a little mini search first, see what else is out there, make sure there's no other systematic reviews already published on this, and then and if not, then we should explore this further.
Is there a pathway back for the knowledge from the systematic review into the field of clinical practice? And can you speak to that pathway maybe for a minute?
Yeah, look, I can speak about my experience. It's at our institution at Flinders Medical Center. So for example, one of the papers that Stephen Cow did on gastrostomies, tubes, and outcomes, we did change our clinical protocol management on these patients. Yeah.
Okay. Is it largely driven by you?
Yeah, largely driven by me. Yeah. So it's a local institutional thing. Yeah.